treatment with planned intervention. For instance, local excision after chemotherapy or local excision after chemoradiation. This is salvage surgery for locally advanced rectal cancer that has not responded with either an incomplete response or a regrowth. So I'm going to give you the conclusions first and then try to support them. The salvage surgery for incomplete responders, it seems like a local excision approach is attractive, taking out just the area of residual disease, which is shown on the left. But I'm going to argue, and I'm going to try to convince you that in that setting, we need to do total mesorectal excision and rectal resection. And these are the reasons, and I'll go on to try to prove this. One, incomplete response represents unfavorable biology. And in fact, response to neoadjuvant treatment is the best predictor of outcome that we have, more than any preoperative imaging or molecular studies. The response to treatment tells us specifically about the biology. And I think this also goes into the lateral node dissection when we look at how the primary responds. Tumor regression is not uniform, so often it's difficult to know the extent of remaining disease. Tumor deposits and extramural vascular invasion can be far from the site of the residual ulcer or scar. And attempts at non-anatomic resection, such as local excision, can limit future definitive salvage surgery. So it just seems like yesterday, but now it's over 20 years ago when Dr. Habergama presented her series of non-operative management or watch and wait in patients that were eligible for surgery. Now, we had data from before this. The Princess Margaret Hospital showed us that radiation alone could control disease for quite a long time, maybe indefinitely in patients that were infirm and not candidates for surgery. But this was really the first organized report of specifically holding off on surgery in patients that received preoperative treatment. And fast forward 20 years ago, this has now become standard, really to speak to her genius. And in fact, if we look at our own patients at Memorial Sloan Kettering Cancer Center, 80% of patients that received preoperative, with rectal cancer that received preoperative treatment, go on to an active surveillance, which is really quite amazing how the field has shifted. The principles of watch and wait are that a sustained clinical complete response is equivalent to a pathologic complete response. And this is Habergama's finding. And it seems obvious to us now, but 20 years ago it was not. And when she presented it, most people did not take her seriously. The second principle of watch and wait is that response evolves over time, and therefore you have to be patient. In the same way, the majority of regrowths occur within 2 years, and we heard about this. The vast majority in 1 year, but then we get up to about 90–95% will occur within 2 years if it's going to happen. Regrowths also develop over time, and that means that patients can be salvaged with surgery. And that's why watch and wait works. Delaying the definitive surgery appears to be safe without any long-term effect on survival. And salvage generally requires rectal resection. Again, going back to the Oprah trial, this is a critical trial because it's the only trial that was prospective and randomized. And again, we took stage 2 and 3 patients and we randomized them into induction FOLFOX followed by chemoradiation, or chemoradiation followed by consolidation FOLFOX. So it was a sequencing trial. And then we reevaluated after the treatment. The best part about this trial was that it had standardized surveillance and response scoring. None of the other trials do. They're all retrospective. The treatment they got was varied. How they were followed was varied, and what was meant by a complete response was varied. But in this trial, it was standardized, as was the follow-up. And then response was determined by endoscopy, digital exam, and MRI. And as I had mentioned earlier, the trial was very different because we dealt specifically with the near complete responders. Complete responders observation, incomplete responders observation, but in this trial, near complete responders went on to observation. And that's why the complete response rate was so high. They were then followed. Those that had a complete or a near complete response underwent surveillance. Regrowth was treated with rectal resection. And in the near complete response, they either went on to a complete response or an incomplete response. And I'll give you the exact numbers. So at the initial evaluation, what was so interesting is that 74% of patients had a complete or near complete response and underwent active surveillance. 26% had an incomplete response and underwent rectal resection. And those numbers were similar between both arms. And so this time bias did not seem to be a major factor. And I was really shocked by this because I just assumed that the more time from radiation to evaluation would result in more response, but it was 72% versus 76%. As we had mentioned, regrowth mostly occurs within the first 12 months, and that's the time of the most intense surveillance, every 3 to 4 months with examination, including flexible sigmoidoscopy in the office and MRI. And almost all recur, if they're going to, almost all will regrow within 2 years. So the regrowth rate is shown on the right upper. And again, the steepest part of the curve is the first year. And there were more regrowths if you got induction FOLFOX followed by chemoradiation. And therefore, rectal preservation was higher if you got chemoradiation followed by consolidation chemotherapy, as we've talked about. And this is where it starts to get interesting. The clinical response predicts TME-free survival, or the ability to save the rectum, or active surveillance. If you have a complete response at the initial evaluation, you had an 80% chance of rectal preservation. If you have a near complete response, which is really looks very, very good, almost perfect, but not perfect, you had about a 50-50 chance that you would go on to a complete response or not, about 40-60 actually. Incomplete responders, of course, did not. So this tells us a couple things, that your response predicts the ability to save the rectum because it's predicting biology. So poor tumor response to neoadjuvant therapy is an indicator of unfavorable biology. Sorry, the graphic is a little bit off, but this slide shows you that the clinical response also predicts distant recurrence. So a complete response is very unlikely. They have a 90% disease-free survival. Near complete response, about 70%. So the response in the primary tumor is telling you about the tumor biology, and this is very important. So we should listen to that. The non-responders, those have to be taken very seriously. Now, the pattern of regression after chemoradiation is varied. This is a study where patients got chemoradiation and they all had surgery. And the residual disease was 12% in the mucosa, 42% in the submucosa, 60% in the muscularis propria, and 35% in the subserosa. And there were many cases in which there was disease deeper in the wall, but not in the mucosa. So when you look in and you're contemplating maybe a local excision, you can be fooled. In a whole mount study done at Memorial Sloan Kettering, we looked at the pattern of tumor regression. And although 60% or 58% of patients had uniform tumor regression toward the center, like a puddle drying up toward the center, 42% had non-uniform regression. 7% had fragmented regression, like a puddle drying up into multiple small puddles. Or you could have differences in the proximal and distal spread of the tumor in 30%, and tumor without any mucosal involvement in 11%. So trying to plan a local excision would be very challenging in these cases. These are just some examples where we see areas of tumor deep in the wall with no necessarily overlying abnormality. Dana Hayden did a study in 2012, again in patients that got chemoradiation and went right to surgery, where she used a coordinate system to look at the specimens. And she found neoplastic cells 3 centimeters from the gross ulcer. So on the right, you can see the area of tumor is outlined in black. And again, if you were to go in and to try to locally excise just the scar, you would miss tumor. So tumor regression is not necessarily uniform, and tumor deposits, EMVI, can be far from the primary tumor ulcer. The next thing to look at is GRECR2, and this is the effect of a local excision on future surgery. So this was a very interesting and good study that looked at T1 to T3 rectal cancer patients. They all got chemoradiation, and some had local excision and some had total mesorectal excision randomized. If you had a local excision and you had more disease than expected, T2 or residual T2 or T3 disease, or a positive margin, you then went on to salvage TME. So it's saying, what happens if you do a local excision, but then you have to do future surgery? Interesting, the categories are shown across the top in the 3 groups. Local excision, rectal resection, that's what you were randomized to, and then the group that had local excision with TME because you had more disease or a positive margin. The major morbidity was significantly higher if you had a local excision followed by a TME. You disrupt the planes, and that's associated with complication, especially Dindo class 3 to 5 complication. The late side effects were also higher. For instance, the need for a permanent colostomy bag, or sexual excision makes salvage TME technically challenging. I think it exposes the circumferential radial margin to implants, reduces sphincter preservation, increases morbidity. Now, it's not to say that you can't do endoscopic submucosal dissection. This is an advanced endoscopic technique, usually for residual adenoma or high-grade dysplasia, as in this example here. So the primary tumor has responded nicely. There's still some irregularity there. The biopsy shows high-grade dysplasia. So this is a good case for endoscopic submucosal dissection. It doesn't disrupt the wall of the rectum, so future TME surgery is possible. And if indeed it's only adenoma, you've saved the patient major surgery. We looked at our series of patients, 12 patients back in 2022. Interestingly, 2 patients did have residual invasive T1 disease that required additional surgery. So the argument for TME salvage for incomplete responders or regrowth. Incomplete response represents unfavorable biology. Tumor regression is not uniform. Tumor deposits and extramural vascular invasion can be far from the residual ulcer and scar. And attempts at a non-anatomic resection, such as local excision, is associated with increased complication, higher rates of colostomy, and may limit future definitive salvage surgery. For those reasons, for incomplete response or regrowth, in the majority of cases, total mesorectal excision is the best way to go. Thank you.
Thank you very much, Professor Weiser. Any question from the floor? If not, we keep the question maybe later on because we quite a little bit delay from the schedule. Sorry about that. But the next is the last session for this morning. We have one case of the rectal cancer, and we have our expert to discuss the case. Actually, this case is not like a discussion because the case is not finished yet. But we would like to ask you about your opinion, how to we manage this case for the next treatment. I would like to invite our discussant to the front. First is Professor Weiser. Second, Professor Shuship and Professor Art. And Professor Chanchila and Professor Kitaya, please come to the front. Thank you very much. And the case will be presented by our youngest MIS, Dr. Tikampon. She just returned from MSKCC with Professor Weiser. Amy, please.
Hi everyone. For the first case, slide is not show. Okay. For the first case, is a 78 years old male presented with bowel habit change and lower GI bleeding for 3 months. He got a